We want to welcome everybody to the 7th and final webinar in our series on COVID-19 and advanced HIV disease care. Let me turn it over first to Bruce Strumminger from the ECHO group, who's going to take us through some of the housekeeping to get us started.
Great, thanks Tom, and welcome to our guest presenters today and to all the participants. There are over 100 people that have gotten through the door so far. And I'm going to share some slides with a few housekeeping items. Hopefully you can see those. And the title of today's session, The Future of CrAg Screening and Treatment. We've got a great lineup of guest presenters, and Tom will be introducing those in just a moment. Back to the housekeeping, we do have Spanish and French interpretation, and if you go down to the bottom of your Zoom window next to the Q&A button, you'll see a little globe, and underneath it, it says interpretation. If you click on that, you'll have a choice of both English or French and Spanish, as well as English or no interpretation. You'll hear exactly what's being said. So for our Francophone and Spanish-speaking colleagues, please take advantage of that simultaneous interpretation. If you've got any IT issues, please go to the chat and chat with ECHO IT, and Matt will try to help you with those. There's a Q&A feature. We really want you to share the questions you've got about today's topic, and we'll be looking in that Q&A space for your questions and any comments, and we're going to try and answer as many of those as we can. The presentation slides and a link to the recording will be shared by email for everyone that registered for this session. The session is being recorded, and your attendance is consent to be recorded, so thank you for that. And we will, there'll be an archive of all the recordings of this series, and you will get an email with a link to all those recordings. Also, there is continuing professional development available through the University of New Mexico. We will be sharing a link in the chat about 15 minutes before the end of the session. And there's a brief survey. We really, really value your feedback. That's how that's what informs us so we can improve. And we'd love to give you CME and CPD points in return for that. So thank you for joining us today, and Tom, back to you.
Great, thanks, Bruce. And let me share my screen and just welcome everybody to, again, this 7th and final webinar in our series on advanced HIV disease, maintaining care in the COVID-19 response. We're excited to end our series on some sort of future hopes and opportunities, and specifically talking about cryptococcal disease management. And myself, Tom Chiller, Chief of Mycotic Diseases at CDC, Alex Jordan, my colleague, and Amir Shrufi in South Africa are hosting this session today. I think the key is ART scale up. You know, we all talk about ARVs, test and start, etc. But we all know, all of us out there working in this area, that more is needed to save lives. Although scale up is crucial, critical, #1 priority, we still see AIDS related mortality. And so it's not the silver bullet that we would like it to be. We know even in countries that have achieved decent scale up, advanced disease is still occurring. So it's important to think about advanced disease as a comprehensive, programmatic approach to taking care of our patients with HIV. Specifically, there are some limitations that we've found now through the years in addressing crypto. One of the big killers, as you all know, limited access to rapid cryptococcal tests, but that's improving. limited implementation of a routine CrAg screening as part of HIV care, also improving. In some low and middle income countries, very little access, unfortunately, to the most effective drug regimes, and we're going to hear about that today. Available drugs that are there are often not optimal due to limited effectiveness and or toxicities. And of course, you know, these are challenging patients to manage in the hospital. So the key would be to try to keep them out of the hospital and catch them earlier in their disease. You know, I think we can optimize some of the patient management strategies with some tools that we already have. But again, that's going to count on getting them into the hands of the people that need them. Rapid initiation of preemptive therapy for CrAg positive individuals as part of screening. And we're going to hear more about some of the challenges with that in the future. Getting everyone a flucytosine containing regimen is key. We know that reduces death and saves lives, and we need to do that. Improving access to liposomal amphotericin B is one of our priorities, and especially in patients with some renal challenges. But this drug could be used in a shorter course, and we're going to hear again about that today. Improving hospital management is always one of the keys to better cryptococcal outcomes. So let's put out a benchmark, a goal, a vision, a mission. Let's end crypto deaths by 2030. Can we really get crypto down to zero? Well, we got to shoot for something. We got to shoot for something big. So beyond just the scale up of ART, which again is critical, what else do you all think will be needed to try to achieve this? What would this look like at the HIV program level? So let's commit to end cryptococcal disease as a major cause of death within our patients. Just providing you this for the recording. And again, thanks for allowing me to give just a brief introduction. Let me now introduce our first speaker, Dr. Tadeo Kandole out of Uganda at the Infectious Disease Institute in Makerere University. He has done lots of work with crypto meningitis through the years in one of the centers that is really bringing us cutting edge research on this disease. So Tadeo, I turn it over to you.
Yeah, thank you so much, Tom. Once again, I'm Tadeo Kandole from the Infectious Disease Institute, Makerere University. And I'm happy to present about the semi-quantitative CrAg test and its potential usefulness in CrAg screening. Well, cryptococcal disease is a lead cause of morbidity and mortality in the sub-Saharan Africa, estimated to cause 75% of the global death. And the presence of cryptococcal antigen will tell you that the disease disseminated somewhere. So detecting it both in blood and knowing its titer is important because it is associated with cryptococcal meningitis. So when you do it early detection of this disease, then you get on a better ground to manage the cryptococcal infection. So on the next slide, talking about CrAg testing. So we need a better test to be able to have a reliable result that makes you be able to diagnose the disease very fast and make a fast decision. Well, currently we are using the FDA-approved CrAg lateral flow assay as a reference standard. It has a good sensitivity and specificity for cryptococcosis. However, it has some diagnostic performance limitations, and in this case, the false negatives. We have observed these false negatives in patients with cryptococcal meningitis, and most of them are because of the proson phenomenon. We can call it the hook effect. We've seen it both in serum and cerebrospinal fluid. So how do you get over the CrAg LFA giving you a false negative because of a proson phenomenon? So you have to do serial deletions, which requires multiple tests to be done At the same time, it increases clinical intervention time, thus delaying treatment. At the same time, in patients with cryptococcal anemia, a CrAg titer is important because it can determine the treatment modality, but still you need a CrAg titer. And with the CrAg LFA, you must use serial dilutions. Again, treatment is somewhat delayed. So that's when we need a better test like a CrAg semi-quantitative test, the CrAg SQ. So the CrAg SQ proves to be better compared to the current need of crypto diagnosis. So talking about the CrAg SQ, it's an immunochromatographic LFA for the semi-quantitative detection of the CrAg in serum, plasma, you can do whole blood or CSF. Still gives you a perfect result. In one single test, you're able to have a semi-quantitative test, which is very much different from the traditional semi-quantitative of testing that would require many tests and serial dilutions and more time going on. However, this CrAg SQ utilizes a different mode of interpretation and testing compared to other rapid diagnostic tests that have two lanes, the control and the test line. But here we're having the control, then two test lines, test 1 and test 2. So talking about this briefly, test 1 is a sandwich line. It contains mobilized and cryptococcal antigen monoclonal antibodies. And then test 2 is an inhibition line. It contains mobilized cryptococcal antigen. So in the picture here, on the next slide, we see the CrAg SQ. It has increasing positivity from low positive to high positive. And the figures you're seeing down here, these are the titer values that correspond with these CrAg SQ titers from the CrAg LFA. So you could look at how a negative looks like after the other increasing positivities compared to the usual rapid diagnosis. So a +1 at 2, 3, and 4, 5, you see a +1, the intensity of the T1, and that is the sandwich line. It is weaker than T2. And at test 2, at +2, we have the same intensity. At 3, T2 is weaker. At 4, T2 disappears. And 5, T1 and T2 disappear. So we need to remember that we talked about something called a Poisson phenomenon, and this is how the strip overcomes it, being able to handle a lot of antigen concentrations. So where you see at +5, T1 and T2 disappearing, probably with the CrAg LFA that is currently under use, you'll be having a negative result because of a Poisson phenomenon, which is not available here. And if you look at the interquartile range of the CrAg LFA, a +1 means a low antigen concentration in that very particular sample. So ranging from 1 in 5 to 1 in 10, a +2 ranging from 1 in 40 to 1 in 60. So our cutoff is at a +3, which shows that you're having a high concentration of the cryptococcal antigen in that particular sample. So using this interpretation, when you do one CrAg test of the CrAg SQ, you're sure that you're having both the qualitative and the same quantitative test to guide you. So like we see on the next slide, how this test is very useful in the CrAg screening. It provides patient risk stratification. It determines the potential risk of developing meningitis in patients with cryptococcal anemia. Because when you have your test and you have a cutoff test of +3, that means you're having a theta which is above 1 in 160 compared to the CrAg LFA. So you're able to determine, to know that this patient could be at a threshold of transitioning from asymptomatic to symptomatic anemia or meningitis. It provides treatment modality by risk. So the clinicians can easily determine the modality of treatment, especially in patients with asymptomatic anemia. Overcoming the prozone phenomenon, this is one of the beautiful things that still is very important, because if you see a patient has many symptoms that you suspect crypto, and the test tells you it's negative, but you still suspect crypto. So here immediately you'll be able to know that it's either crypto or not crypto, because the strip accommodates very high concentrations of cryptococcal antigen, thus no more negative results from a hook effect. It's able to predict the fungal burden in meningitis, and remember, easy to have the qualitative test result, and it's tighter in only 10 minutes. So you have that benefit of rapid clinical intervention and decision right away with the CrAg SQ compared to the current FDA-approved CrAg LFA. So in conclusion, we say it's a reliable diagnostic tool providing both qualitative and some quantitative results. And these all aid in risk stratification treatments of patients with cryptococcal disease, thus serving as a better diagnostic tool in CrAg screening. I thank the IDI Research Department, the meningitis team, study participants, Professor Bolware, Dr. Kathy Hapler. Thanks for listening to me.
Excellent. Thanks, Tadeo, for a great presentation on some of the future ways to screen and think about our cryptococcal antigen. Let's keep moving on with presentations so we can get good time for questions. I'm pleased to introduce Ray Wake, who is an academic clinical lecturer in infectious disease and micro at St. George's Hospital in London. She has worked for many years with our colleague Nilesh Govender at the National Institute for Communicable Diseases in Johannesburg, South Africa, and has lots of experience directly dealing with patients with cryptococcal disease. So Ray, we're thrilled to have you. And let me also introduce Tom Harrison, who will be fielding questions as well on the panel. Tom is a longtime warrior against the Cryptococcus fungus. He's a professor of infectious disease and medicine and the deputy director of the Institute for Infection and Immunity and the lead at the Center for Global Health. He's also an honorary consultant at St. George's himself, and again has worked and really helped us lead the way in trying to save lives from cryptococcal meningitis. So Ray, I turn it over to you for the next talk. Thanks.
Thank you, Tom. I'm just going to share my slides here. Is that okay? So yeah, thanks Tom for the introduction. It's great to be part of this webinar today. And as Tom said, I'm speaking to you from London, and I'm just going to briefly present some of my data from South Africa, and then hand over to Tom Harrison to fill in and correct anything I've said, but also to fill us in on the future of clinical trials for cryptococcal antigenemia. So as I said, I was going to present some data from Johannesburg, where I was previously working with Nilesh Govender, studying the CrAg screening around there, and specifically investigating why we seem to see poor outcomes in some patients with asymptomatic CrAgemia, so CrAg positive patients, following preemptive fluconazole. And therefore the potential advantages of using alternative cryptococcal meningitis treatment regimens instead in these patients. So this is the CrAg screening and treatment strategy implemented in South Africa since 2013, and which was operating nationally during the time I collected the data that I will present. So this strategy involves assessing patients who are reflexively tested as CrAg positive, and they are asymptomatic, then starting them on a course of fluconazole therapy using 800 milligrams for 2 weeks, and then 400 milligrams for 2 months, and then following on with a 200 milligram daily dose. And I'm sure we'd all agree that this strategy has great potential for saving lives in patients with advanced HIV disease, And indeed, there's now prospective evidence that fluconazole does reduce the incidence of cryptococcal meningitis in patients who are asymptomatic with CrAgemia, so who are CrAg positive, and the risk of mortality in these patients. However, there is a concerningly persistent increased risk of death in patients, in CrAg positive patients compared to CrAg negative patients with similar CD4 counts. And I followed 67 CrAg positive patients, 134 CrAg negative patients in Johannesburg with similar CD4 counts, and found that CrAg positive patients were around 3 times more likely to die than CrAg negative when adjusted for age, sex, and CD4 cell count. And this finding is consistent with previous and other prospective screening studies using preemptive fluconazole, where although the reported incidence of cryptococcal meningitis was much lower than one would expect without preemptive therapy, the risk of death was around 2 to 4 times higher in CrAg positive patients as compared to CrAg negative patients when adjusting for CD4 cell count. And this is particularly the case in patients with a high CrAg titer, as was previously mentioned, over 160 seems to be a cutoff with a particular high risk. However, throughout these studies, it's not very clear what the causes of death are. And certainly the very low incidence of cryptococcal meningitis implies that mortality risk might be secondary to non-cryptococcal causes. So in Johannesburg, I aim to establish the importance of cryptococcosis in driving this excess mortality. So firstly, establishing the burden of cryptococcal disease at baseline at the time when patients are tested for cryptococcal antigen, during 6 months of follow-up, and to make careful assessments of the causes of death in these patients, including by using minimally invasive autopsies or autopsies. So when patients did have lumbar punctures, which weren't routinely performed, but were performed in some patients without symptoms, we found that subclinical cryptococcal meningitis was present in around a third of patients. And this was much more likely in those patients with higher blood CrAg titers. And so the concern is that in the vast majority of cases where lumbar punctures are not performed, fluconazole monotherapy is inappropriate for what is actually already a CNS infection in around a third of patients, despite the lack of symptoms or signs of meningitis. And the updated Southern African guidelines showed here recognise the importance of excluding subclinical cryptococcal meningitis by emphasising that all CrAg positive patients should really be having lumbar punctures. And this is, of course, an important change. Theoretically, this would identify patients with the highest risk of death and make sure that those patients with cryptococcal meningitis receive appropriate therapy with an amphotericin-based regimen. However, it's of course difficult to offer lumbar punctures or to ensure patients have lumbar punctures in all settings. And we all know that it's difficult to persuade patients to have lumbar punctures, particularly when they're feeling well, they don't have any symptoms or signs of meningitis. And the other problem is that, unfortunately, I think baseline lumbar punctures don't completely solve the problem, as even when cryptococcal meningitis is excluded at baseline, there's evidence that fluconazole fails to prevent cryptococcal-related deaths. So in this Johannesburg cohort of 67 CrAg positive patients, 85% had baseline lumbar punctures, and we also looked for crypto in blood and sputum cultures. So 50 of these patients had no evidence of cryptococcal disease at baseline following these tests, and 12 of these patients died, so 24% died during the following 6 months. And on careful analysis of the causes of death in these patients, in these 12 patients, 7 deaths were found to be cryptococcal related. Furthermore, we found evidence of cryptococcal disease in 4 CrAg positive patients who died. 3 of these patients had baseline lumbar punctures which were negative, and all of these patients became confused before death, and then cryptococcus was identified post-mortem in CSF samples, in BAL samples, and histology. So hopefully I outlined some of the reasons why an alternative treatment regimen is needed for these patients with asymptomatic CrAgemia. And the most obvious choice is obviously to use drugs that we have experience of and know improve survival in the context of overt cryptococcal meningitis, and particularly using those drugs with reduced toxicity and side effects. So the Acacia trial is randomizing asymptomatic CrAg-positive patients to a single high dose of liposomal amphotericin B in combination with fluconazole, or to a standard care of fluconazole 800 milligrams. And this trial started enrolling in Uganda last year, and we should have results in around 3 years' time. So giving only a single dose of IV ambisomals obviously has the benefit of reduced cost and burden of prolonged hospitalization and toxicity. And I'll leave the detail of the ambisome in the treatment of cryptococcal meningitis for Joe Jarvis to speak about in the next session. But briefly, this dose used in Acacia has been shown to be well tolerated and non-inferior to a standard 14-day course in a phase 2 trial examining early fungicidal activity in CSF patients with cryptococcal meningitis, and is currently in the treatment arm of the phase 3 trial Ambition, which is also for cryptococcal meningitis patients. A randomized controlled trial is planned to start next year in Tanzania and South Africa. So this is the EFFECT trial, which will compare initial treatment with 2 weeks of flucytosine and 1200 milligrams of fluconazole with standard care of fluconazole at a high dose of 1200 milligrams, which is consistent with local guidelines. This will also exclude patients with subclinical cryptococcal meningitis. And again, using evidence from previous cryptococcal meningitis trials, the ACTA trial demonstrated this combination is well tolerated and is as effective as 2 weeks of amphotericin B plus flucytosine in patients with overt cryptococcal meningitis. And it's important that we have a look at randomized trials in this different group of patients with asymptomatic cryptococcal antigenemia. So the oral combination is obviously also a very attractive option in this population, since it avoids any need for hospitalization and IV access, as a reduced rate of side effects as seen in ACTA. And it's also timely to be doing this trial at a time when we anticipate increased availability of flucytosine across Africa. And there is a potential of a modified release formulation that we'll hopefully hear a bit more about from Tom Harrison and others. So thank you, and just hand over to Tom if you wanted to fill in any more detail on that.
Thank you very much, Ray. I think that's an excellent summary, and I don't have much to add, just to say that I think we're very pleased, obviously, that the EFFECT consortium has now been funded, and that there are now 2 randomized trials looking at stronger antifungal treatment in the context of screening. And I mean, I do think the robust data coming out of these 2 trials will help drive forward the screening agenda, and hopefully lead to improved outcomes, and also improved enthusiasm for screening in general. If we can show that the strategy, if we can improve on the strategy in terms of the outcomes. Yes, and as you mentioned, and I think we're also pleased that the work to develop a modified release flucytosine formulation is going ahead, because that could be particularly important in patients taking flucytosine as outpatient therapy. 4 times a day is a challenging dosage to take, and it's we hope very much that a modified release formulation will be able to be taken just twice a day. And I think Isabella Ribeiro from Drugs for Neglected Diseases Initiative, the DNDI, who is leading that effort, may be on the call and might be able to comment later. But there's already been some work done on that formulation, and phase 1 and phase 2 studies planned. So I think that's all I wanted to add.
Great. Thanks, Ray. Thanks, Tom. And really look forward to the EFFECT trial. Congratulations on finally pushing that through. I know that that's been a struggle for many years, and I'm glad you were persistent and you kept up the efforts to make that happen. That is a really exciting, addition to the future management of crypto and our goal of 0 deaths by 2030. Let me introduce our final speaker. You've already heard his name, Joe Jarvis. Joe is a professor currently based in Gaborone, Botswana, but has been in several countries in sub-Saharan Africa throughout his career. And again, another long-standing expert in cryptococcal meningitis, and has really helped us think through screening and get that started, and has been focused more recently on shorter courses of therapy, more rational therapies for cryptococcal meningitis. He is currently with the Botswanan Harvard AIDS Institute Partnership based in Gaborone, as I mentioned. Joe, please take it away.
Great. Thank you very much, Tom, for the kind introduction. I'll just stop my video and share the screen with you. Great. So hopefully you can all see my first slide there now. So I'm going to talk, as Tom said, about the role of liposomal amphotericin B in cryptococcal meningitis management. And I think for this audience, we've already heard quite a bit of background in the last couple of talks, but we know that mortality rates with current antifungal therapy for cryptococcal meningitis remain unacceptably high. And in Botswana, in keeping with many countries in Southern Africa, we still don't have access to flucytosine and currently rely on standard amphotericin B deoxycholate plus fluconazole for treatment, which is given for 14 days. And these are some data from Seppo Leme, one of the study doctors on the research team here in Gaborone, Botswana, just looking at outcomes with 2 weeks of amphotericin B deoxycholate-based therapy in routine care settings. And this was 236 patients. And you can see that the outcomes really are not great. We had 26% mortality at 2 weeks, and 50% of patients were dead by 10 weeks. So we really need to do something and get them improved treatments. And part of the reason we're seeing such poor outcomes, I think, with 2-week courses of amphotericin B deoxycholate with fluconazole, is that we're trying to manage this very toxic and difficult to give drug in settings like this. This is Seketure Hospital in Tanzania, which was one of the collaborating sites on one of the phase 2 trials I'm about to talk about. And what you notice there is notable by its absence, really. You don't see any drip stands. You don't see many patients getting intravenous infusions. There are very few nurses. Relatives provide a lot of the nursing care. And if you go through the back door there along to the laboratory, you'll find that the laboratory machines for measuring your serum creatinine and potassium and even hemoglobin are often out of reagents and unable to function. So in this setting, it's very difficult to give a drug like amphotericin B deoxycholate, which causes quite profound thrombophlebitis. If drips are not managed carefully, it can lead to nosocomial sepsis in a large number of patients. You can get infusion reactions if it's run too fast. It causes quite profound anemia. We see an average drop of 2.3 grams per deciliter of hemoglobin over 14 days of treatment. It can cause renal impairment and potassium and magnesium wasting. So we really need to find treatments that are easier to give and more practical to give in settings where the majority of our patients with cryptococcal meningitis are being treated. So what could we do? Well, one potential option, which you've already heard a bit about from Ray and Tom, is giving shorter courses of standard amphotericin B deoxycholate. So these are some animal model data from rabbits looking at giving either the standard 14-day daily dosing of amphotericin B deoxycholate, or just 3 doses on day 1, 2, and 3 in this rabbit model of cryptococcal meningitis. And what they showed in the panels on the right there, that's looking at the fungal burden in the CSF of these rabbits, is that you get almost the same clearance of infection from the CSF with the 3 doses as you do with 14 doses. And if you look at the brains of these rabbits at the end of treatment, the fungal burden in the brains was almost the same with just 3 doses versus 14 days of dosing. And Tom Harrison and colleagues have now proven that this is the case in people as well. So this is more data from the ACTA trial. Ray showed you one panel from this study. And what we saw, or what Tom and colleagues saw in the ACTA trial, was that 1 week of amphotericin B deoxycholate given with flucytosine was as effective as 2 weeks of amphotericin B deoxycholate given with flucytosine. In fact, the mortality was lower with 1 week compared to 2 weeks, probably because you're getting very good antifungal activity, but you're avoiding some of that toxicity. So this demonstrates that short courses of standard amphotericin B deoxycholate can work. But it's notable, if you just look at the box there showing 1 week of amphotericin B deoxycholate plus fluconazole, that for these 1 week shortened amphotericin B deoxycholate courses to work, it looks like we have to give it with that fungicidal drug flucytosine, because if we give it with fluconazole, we see quite high mortality. So in the ACTA trial, that was 49% compared to just 24% with 1 week of flucytosine. So what about liposomal amphotericin B? Well, and recently there was very little data about this. There was one study which had looked at only about 250 patients with HIV-associated cryptococcal meningitis, done many years ago, 1995 to 98, although only published in 2010. And they compared standard amphotericin B deoxycholate 0.7 milligram per kilogram for 14 days versus liposomal ampho at 3 milligram per kilogram or 6 milligram per kilogram for 14 days. And what this study showed was that the efficacy of all three of these treatments was basically the same. There wasn't any particular benefit to giving liposomal amphotericin B deoxycholate. It was less toxic compared to, so liposomal amphotericin was less toxic compared to amphotericin B deoxycholate, much less doubling of creatinine there. But the cost differential was huge. So I just checked what we're paying at the moment in South Africa for liposomal amphotericin B. And what we're paying is 2,778 rand per vial, which at the 3 milligram per kilogram dosing for a 50 kilo patient would be 42 vials over 14 days. That amounts to 116,000 rand, which is over 6,000, almost 7,000 US dollars per treatment course, compared to just $26 for standard amphotericin B deoxycholate. So given there was no major advantage to the liposomal formulations over deoxycholate in terms of treatment efficacy, liposomal ampho was not really used at all in any low or middle income settings. However, we know that liposomal amphotericin B is much less nephrotoxic, so potentially we could give much higher doses of the drug safely. We know that it's got excellent tissue penetration and a very long tissue half-life, so it may be possible to deliver highly effective induction therapy with very few doses. And we know from another disease, visceral leishmaniasis, that effective treatment can be given with a single very high dose of liposomal amphotericin B. So one 10 milligram per kilogram dose of liposomal ampho was as effective as 14 days of standard dose liposomal ampho in this disease. So perhaps in cryptococcal meningitis, we could get over these limitations, particularly the costing, if we could use very short courses, which may make it a very effective treatment option. So to set about defining the most cost-effective schedules, we designed initially a phase 2 study. This was based on some of the animal model data. Again, this is a murine model now, a mouse model showing that if you give a single very high dose of liposomal amphotericin B in a mouse, you get a very rapid increase in your brain levels, shown in the black. And then this drug hangs around for a long, long time. The terminal half-life in the plasma and the brain was around 133 hours. So we performed a phase 2 study in Tanzania and Botswana. We looked at 4 arms in this study, a control arm looking at the standard ambisome liposomal amphotericin B dosed at 3 milligram per kilogram per day for 14 days. We looked at a single 10 milligram per kilogram dose given on day 1. We looked at a 2-dose arm where we gave a large dose on day 1 and a slightly smaller 5 mg per kg dose on day 3, or a 3-dose arm where we gave 10 mg per kg on day 1 and 5 mg per kg on day 3 and day 7, all given with fluconazole. And our primary endpoint for this study was the rate of clearance of infection, shown in these graphs below. And to cut to the chase, what we found, looking at the graph on the right there, these represent the difference in rate of clearance between the control and 3 doses at the top, 2 doses in the middle, and single dose at the bottom. And that's the point estimate with a 95% confidence interval. And you can see, first of all, that all 3 high-dose treatment arms were non-inferior to the standard 14-day dosing in terms of rate of clearance of infection from the CSF. Secondly, you can see that, in fact, the point estimates were all suggesting that clearance was faster with the higher dose short course treatments than with the standard treatment. And finally, you can see that there was no dose response effect there. So there was no suggestion that 2 doses or 3 doses were any better than that single dose. So it seems that the single very high dose may be enough to get maximal drug occupancy binding site, drug binding site occupancy and maximal antifungal efficacy. So based on this phase 2 study, sorry, one slide here, just looking at the safety and tolerability of this, we saw in all of the liposomal amphotericin B arms very low rates of adverse events. And just to put this in perspective, if we compare it to data from our large cohorts of patients treated with amphotericin B deoxycholate, in the liposomal ampho-treated patients, we saw an average of a 14% increase in creatinine over 2 weeks compared to 73% with amphotericin B deoxycholate. And in the liposomal ampho patients, we saw a 0.9 gram per deciliter drop in hemoglobin over 2 weeks compared to a 2.3 gram per deciliter drop with ampho B deoxycholate. So very well tolerated and effective. So based on that initial efficacy data, looking at the rate of clearance of infection, we've gone on to start a phase 3 trial, and we've taken forward the single 10 milligram per kilogram dose of liposomal amphotericin B deoxycholate, and we're comparing that to standard of care, which is now we've given the 10 milligram per kilogram of liposomal ampho, we're comparing that to standard of care, which is amphotericin B deoxycholate given for 7 days with flucytosine from the ACTOR study. And what we're studying is a form of triple therapy here, which we think will hopefully be the best possible challenger to the standard of care established in ACTOR, on the basis that in the phase 2 study, we've shown that a single high dose seems to be the best way to deliver the liposomal amphotericin B, and ACTOR data showing that flucytosine is an essential component and the best partner drug. So we're hoping that this combination is going to be a highly effective treatment for cryptococcal meningitis. Hospitals across Uganda, Malawi, Zimbabwe, Botswana, and South Africa. And as of today, we've got 670 of our 850 patient projected sample size. So we'll hope to have an answer for you on this by the end of this year or early next year. Just our last slide, thinking about, well, could we use these single doses of liposomal amphotericin B in CrAg screening? Well, you've heard from Ray already about the Acacia study, which is looking at a single dose of liposomal ampho in antigenemic patients. I think I'd just like to add to that a bit of our data looking at antigen titers and quantification. This is using the CrAg SQ assay that Tadeo talked about in the first talk. And what you can see is that in a cohort, this is a cohort of patients screened for cryptococcal antigenemia in Botswana now, that the CNS involvement and mortality in CrAg screened individuals in a CrAg screening program is highly dependent on their cryptococcal antigen titer. So you could imagine a situation where in a CrAg screening program, you're using this semi-quantitative cryptococcal antigen assay, and those who have the 4+ or 5+ highest titers on this assay, you could select those out to immediately get the single dose of liposomal ampho. And those at the lower CrAg titers, according to this assay, perhaps you could treat with the oral combination that Tom and Ray are studying in the EFFECT study, or even in the lowest titers, fluconazole, because these patients seem to do well then. So I think there's still quite a lot of interesting stuff for us to look at. And obviously the EFFECT trial and Acacia trials will help with this, about how we manage those CrAg screened individuals as well. So in summary, we hope that a novel, short course, highly effective and safe liposomal amphotericin B treatment for cryptococcal meningitis would transform the management of late-stage HIV and markedly improve outcomes in HIV programs in Africa. We hope that reductions in the need for laboratory monitoring, lower toxicity rates, and reduced durations of hospital admission, coupled with preferential pricing, could make this short course high-dose liposomal amphotericin treatment a cost-effective treatment for Africa. And we'll have definitive data from our phase 3 Ambition CM trial in patients with cryptococcal meningitis by the end of this year or early next year. So a huge number of people to thank who are involved in this study, and particularly Tom Harrison, who's on the call and is my co-principal investigator on the Ambition trial. So thank you very much, and happy to take questions.
Excellent, Joe. Thanks for winding up with another great presentation and really pushing the envelope again and giving us all a chance to see where we potentially could head. It's exciting to see Ambition moving forward, and then a couple of the other trials as well that are going to feed into that. So this is great. We've got a good amount of time for some Q&A. So for the audience, remember there's the Q&A tab down below. I see some of you are already asking questions. We've responded to some of those via text, but we will probably take some of those live as well. Before we jump into questions, we actually had a couple questions for you, the audience, that we wanted to do quickly, some polling questions. So Jutta, I think you have them. There's the first one up. So on the theme of these advanced disease webinars, are you, the audience, interested to continue these echo sessions in some capacity? And we're giving you the option of once a week, twice a month, once a month, or never again. So take a moment to answer that poll, and we'll take a look at the results live. So, okay, let's go ahead and show how you guys are feeling about these webinars.
We're still getting some answers.
You're still getting, that's fine.
Seconds.
Let folks respond. You're in control, Jutta. Thank you. Wow, a resounding 0 for never. That's a good sign, and it looks like it's pretty equally split. So we will take that to heart, and we will see about how we can continue these webinars in some capacity, be they a little less frequent than we've had them now. So we have one more polling question as well. Jutta, please put that up. Thank you. So if we are continuing them, which it sounds like the audience wants us to do, what format would you find most helpful? So the webinar, which is what we've been doing currently, a case study where we present a case and talk about it, more of a combined approach, maybe where we have a lecture and a case, info on access and programmatic challenges that we have in advanced disease, and then all of the above. Let's see how we did on this one. So a combined approach seems to have won out, followed by all of the above. So people still wish somewhat of a potpourri of formats, and that makes sense to us as well. We appreciate you giving us that feedback. So let's move on now to the Q&A part. And I thought what would be good to start with, just because I saw this question in French and I was intrigued by it, and it takes us a little back to the basics. The question was posed, all right, and I think you all remember dealing with this a lot more in the past, but the question says, if I don't have an antigen test, what do I do to diagnose crypto? And obviously that's something that I know Joe, Ray, Tom, all of us have dealt with in the past. We all wish we have antigen tests, but when they're not available, what do we do? So before we talk future, let's maybe talk past. Clearly there are still colleagues out there without antigen testing, and walk us through how you handle those challenging patients. Ray, do you want to take a crack at that?
Sure. Well, the benefit of the cryptococcal antigen test is obviously detecting those patients that aren't clinically obvious to have cryptococcal disease. But of course, without our HIV status, the CD5, and how they are presented with CNS infections, so confusion, meningitis. If you have to diagnose cryptococcal meningitis, and then you'll need to do microscopy with India ink and culture to look for cryptococcus.
Thanks, Ray. We lost you a little bit, but I think we got the gist. I didn't know if Joe or Tom, you guys had anything to add to that challenging situation.
I don't think I've got much to add to what Ray said, really, but just pointing out that in those with suspected meningitis, we've got India ink available. But the fact is that to identify these antigenemic patients at a stage where we can intervene early and prevent the severe morbidity and mortality, we really do need access to these cryptococcal antigen tests. There is just no other way of doing it. So it highlights how important it is that we push access to cryptococcal antigen testing.
Yeah, agree.
Thanks. All right. Thanks, everybody. So, I guess one of the things that I'm interested in from all of you is your, let's say, your ideal algorithm. And I know that, some of that algorithm is going to be based on the trials that we've just heard about that you all are involved in and conducting. But, if you had an idea, if you had the testing and the drugs available to you now in your clinic, which we hope many will in the future, based on the current evidence or current thought process, what is your algorithm for screening and dealing with patients as they come in with advanced disease? So I don't know who wants to take a stab at that one, but anyone can volunteer, or I will actually, let's turn it over to you, Tom, first. What is your algorithm for that patient? What does it look like in an ideal setting based on some of the newer evidence?
Yeah, I mean, I think, Tom, the difficulty is kind of generalizing to an ideal setting, because obviously there are a number of variables, aren't there? There's the availability of the lumbar puncture, there's the availability of the current standard LFA test, there's the availability of a semi-quantitative test, and there's the availability of the drugs. So, I think you've got to remember that all those things play into, obviously also the context of the screening. Are you in a place where screening is currently happening or not? But I mean, if you put me on, obviously as I, you're kind of pressing if resources are no object, if we have all the latest gadgets, as it were, then I do think that the evidence for eventually heading towards some sort of stratification of management, looks convincing. But so the case for the stronger treatment is particularly strong with patients with high titers. But I just wonder whether actually we'll find that patients with low titers might also benefit from more aggressive antifungal therapy. That's why I think we do need, the data from randomized trials, and we need the data from randomized trials, of course, to push policy, because it's not. We unfortunately we don't live in an ideal world, and so all these algorithms have implications for cost for an implementation, and so we need the data to back to be able to persuade policymakers and guideline writers of the robust evidence to push forward. Yeah, have I avoided the question enough? No, I mean,
yes. You've done a good job, but I think that I think your answer is I think your answer is well taken, and I think that I'm trying to push you all a little bit to sort of postulate on what it might look like. But I think your answer is right on, and I think there are some exciting potential, and I think one of the challenges, I agree with you, Tom, is this idea of, do all patients who are CrAg positive need more than just fluconazole? And I think that is still an unanswered question. Joe, Ray, Tadeo, any thoughts, sort of around this algorithm to add to what Tom's already said?
I don't know if you can still hear me. Yeah.
Yes, go ahead.
So I would add, I'd love to emphasize the logistical problems. In the ideal world, getting immediate CrAg results, possibly, if possible, quantitative, so that patients can be assessed and started on, hopefully guided by that titer, by that quantitative results. What I'd like to emphasize is it's not a benign test, and sending patients away from it, the delay involved in progressive infection. I'd just like to add that if possible, let's get some point of care.
Thanks, Ray. We're catching, you seem to be fading in and out. I think it must be your connection is sort of coming and going. But I think we're catching the gist of what you're saying, and we appreciate it. Let me ask a question of Tadeo, because I've got a question here that relates specifically to the LFA and the SQ test, or a titered test. And the question asked, do you think assuming this titer test is going to work well, do you think this should replace all LFA tests, and that we should only be doing titered LFAs?
Yeah, thanks, Tom. In my view, the CrAg SQ is a perfect replacement for every type of CrAg LFA because of its performance. And when you look at some other tests that are available, especially, we have looked at the CryptoPS. It is not that very nice. And actually, the CrAg LFA is much better than the CryptoPS. We are looking at the Dynamica, some Chinese type as well, but still, it's not as better as the current CrAg LFA. So the SQ, in my view, would completely replace the CrAg LFA for its performance. And to talk about the past discussion, more things need to be done, because when you put such tests to the medical workers, training should be done, even if it looks so obvious that this is a simple test to use, because sometimes people may just do the test, yes, and this is how it works, but people should get more training about something new so that we can always know where we're going. Sometimes here in Uganda, some health facilities can refer patients, but we have a patient with a positive cryptococcal antigen test, but usually when you repeat it at the health facilities here, to the Infectious Diseases Institute, you find well, the patient doesn't have the disease. So, and also making sure that people know exactly which type of test they use, because the latex agglutination test is still present, but they still report as CrAg positive or CrAg negative, but maybe specifying exactly which kind of test was used is very important, so that you can know we are either going the right way with the test or the wrong way with any type of test. But ideally, it can replace the CrAg LFA types of any kind perfectly.
Great, thanks for that response. A couple questions, Joe. I'm going to refer to you on for these couple of questions. This is there's some good questions on just meningitis management. So one question is about other than CFUs and clinical improvement, are there other ways that can help us look at the efficacy of treatment in resourced limited settings where obviously standardized fungal culture is not available?
Thanks, Tom. So that's a good question. So colony forming unit counts are basically being used as a research tool. They're not really used in clinical practice in general to monitor outcome. So I think in terms of clinical practice, what can we do other than clinical monitoring? Well, the answer is very little, really. We wouldn't really recommend doing repeat fungal cultures unless there's a particular reason to do it in routine clinical practice. There certainly have been previous discussions about, well, should we continue treatment until we've got negative cultures? But the issue with doing that is that, first of all, when you send a culture, particularly when somebody's been on treatment for a few days, it can take many days for that culture to come back, which would end up with very long treatment courses for everybody. And now, of course, we have data from the ACTA trial and to some extent the phase 2 ambition trial suggesting that actually these very short courses of treatment seem to lead to lower mortality, even though several of the patients are still culture positive once we've finished those short courses of treatment, but there seems to be this residual antifungal effect. So basically your monitoring of these patients is clinical.
Thanks. And I know you already addressed the written question about raised ICP, but could you just go ahead and just give us that question orally as well, or answer that about persistently raised intracranial pressure and mortality and what you do?
Yeah, so raised intracranial pressure is, as everybody who's managed crypto knows, a huge problem in our patients. And well over half of the patients do have raised intracranial pressure either when they present for the first time or they develop it over the course of treatment. And we know that if that pressure is not managed properly, then it will lead to poor outcomes and mortality in patients. And the way we manage that is with frequent lumbar punctures, measurement of the pressure, and drainage of CSF to normalize the pressure. Sometimes that has to be done daily for several days, sometimes even weeks. But in our clinical trials that have been conducted across South and East Africa over many years with Tom and colleagues in Uganda at IDI and others, it's clear that if you manage that pressure aggressively with those frequent lumbar punctures, then there ceases to be an association between raised ICP and mortality. So you can effectively manage it and stop it being a mortality risk with frequent lumbar puncture.
Thank you for that. Challenging indeed. Tom Harrison, over to you. Let me try to push you again. So if considering the constraints, now I'm giving you the real world situation, considering the constraints many clinics have in using IV medicines, would you not prefer the all oral? Now this does say that you have access to 5FC, the all oral treatment over trying to logistically get a patient to a facility where you can administer IV?
Well, I mean, Tom, I'm going to say that we need some evidence from randomized trials, and with the Acacia study and the effect study, we may be able to look across studies and see which approach is better. But I do think that the all oral regimen has important feasibility advantages, because there's no doubt that however much counseling you give to patients who are CrAg positive, who are truly asymptomatic, feeling well, they will be, a large proportion will be very reluctant to come into hospital, have a lumbar puncture and have IV treatment. So the all oral regimen is, there might not be one size fits all, but I think the all oral therapy is certainly an attractive option, and it will be suitable for such patients. And I mean, I think that the progress that's being made with access to 5FC, I really think there is room for optimism that availability of 5FC will increase. I mean, it's already increased. We know it's already being used in routine management of cryptococcal disease in South Africa. So I'm an optimist about the availability of 5FC into the future. So I think it will be a very important option. And I mean, if you look at the ACTA trial results, the oral arm did very well in patients. And we looked within ACTA as to whether the oral regimen had any performed poorer in the sickest patients. But there wasn't any hint about that, actually, that the oral regimen was more inferior to the comparators in the sickest patients. We didn't see that. So it does seem to be an effective regimen, even for quite sick patients.
Great, thanks. Let me go to you, Tadeo, to ask a question that was raised about the CD4 count level for screening for CrAg. You know, there has been some movement in recent years that we move from a lower CD4 count to a slightly higher CD4 count for screening. There was a study where there was some mortality benefit below 200. And of course, WHO is defining advanced disease as 200, making it maybe a more universal and easier programmatic cutoff. What is your feelings about where we should screen in terms of CD4 cutoff?
Thanks, Tom. So my feeling should be below 200 CD4 cells, but if possible, for a facility to have a viral test, so that if a patient has also 1,000 copies of the virus, the heavy virus, should also be screened for a CrAg, because this is something very rare, but if a facility is also able to have viral testing, it should be able to screen at least for patients who have 1,000 copies and above. Then for the CD4, 200 at least and below.
Great, thanks. Another question that came in, just because we are talking about COVID and we're all dealing with COVID right now, does anyone on the panel know of any sort of COVID crypto comorbidity, co-infection phenomena? Have any of you been seeing, you know, COVID and crypto together or heard of cases? Sounds like not. So,
Well, I say in Botswana, Tom, we're still very fortunate in that we haven't had many COVID cases here. I think that the place that may be seeing it would be South Africa, where of course they have very high incidence of coronavirus now and quite a lot of crypto. But I've not heard of any interaction between crypto and COVID yet.
Yeah. I mean, just to add, Tom, I mean, I think, I haven't got any experience either, but I mean, I think there was some concern when, you know, everyone was talking about chloroquine and lopinavir as possible COVID treatments, that, you know, chloroquine would not be good in a crypto patient on fluconazole because they're both strongly QT prolonging. And also lopinavir obviously could upset antiretroviral therapy. So, but hopefully those issues are less pressing now that both have been shown not to be helpful within the recovery trial.
yes, thanks for raising that. Very good point. I'm opening it up now in these last few minutes. Does anyone else have question, Alex or Amir, anything that you've seen that would be a good couple questions for the end?
Yeah, maybe, thanks, Tom. We've heard about the all-oral regimen from the ACTA trial. Joe, we've heard from you on the prospects for high-dose liposomal amphotericin B, followed by an all-oral regimen. What are people's thoughts, particularly in settings where inpatient capacity is scarce and sometimes a constraint? How short could we safely think about reducing the inpatient management phase 2? For Tom or Joe or Ray or whoever would like to take that. But that is a question that comes in quite a lot from some of the implementing organizations.
Yeah, well, Amir, it's a very difficult question. So in ambition, in the study that we're doing, we've been, because it's a trial of a novel treatment approach, and we have to be very careful about safety, we're ensuring that all of the patients stay in for a minimum of 7 days. So we're generally discharging our clinical trial patients at day 7 if they seem to be clinically stable at that point. And we certainly haven't seen any problem with that. So I think there's no question that you could reduce duration of hospitalization by half from your standard 14 days that we were doing before when we were giving amphotericin B deoxycholate induction to 7 days. We are collecting data about when the patient would have been hypothetically ready to be discharged home, to try and get a better idea of what the duration of admission is likely to be in the majority of patients treated with the single dose liposomal ampho arms. The reasons for maintaining people in hospital are, of course, one, management of raised intracranial pressure and ensuring that we're monitoring for that and doing lumbar punctures to check for that. And secondly, because we all know that there are a number of patients who can deteriorate quite rapidly and sometimes unexpectedly in the first few days of their treatment. So I think the jury is still out. I'd certainly say that 7 days seems to be fine in our trial. I think you could almost certainly go a bit shorter than that, but it's going to require some clinical judgment and stratification. Tom, I'd be interested to know what your thoughts are.
Yeah, no, I agree. So what we're talking about is treatment of symptomatic cases and the duration. I mean, if we're allowed to postulate, or we're encouraged to postulate, say the ambition phase 3 does show that the single dose with the oral combination is a very effective therapy, then if you're in a setting where you've got the flucytosine, but you don't yet have the liposomal, how many days, could you substitute a number of days of deoxycholate, 3 or 4 days, in the context of flucytosine, of the oral combination as a backbone? Probably that would be an effective treatment, so a number of days up to 7 days, and probably 1 or 2 days less than 7 days would still be very effective in the context of the oral combination as your backbone.
Great. Well, we're right here at the end, and I just wanted to pose one more question because it came up, and I think that it's one of those challenging issues as well. But just if you guys can briefly comment on dealing with iris, and is there a management strategy that you use for dealing with immune reconstitution inflammatory syndrome? Joe, Tom, Ray, Tadeo, anybody jump in. Then I'll throw it to you, Joe.
Okay, so management of iris. So we used to see a lot of cryptococcal iris, and I think particularly if you look back at studies that were using less fungicidal treatment regimes for the initial treatment of cryptococcal meningitis. When we started ART in those individuals, we saw quite high rates of iris. Maybe a third or more of patients were developing some degree of paradoxical iris when we started ART. Since we've been using much more fungicidal treatment regimens, particularly amphotericin and flucytosine-based treatments, we see far less iris. So in our study, we're seeing much less iris than we used to see in the very early days. So I think the best way to manage iris is to stop it happening altogether, and the best way to do that is by giving people very effective antifungal therapy to begin with, and then starting antiretroviral therapy in keeping with the COAT trial, which would suggest you start 4 to 6 weeks after you've initiated induction therapy for those patients. If patients still do get paradoxical iris, and of course some of them do, then our standard management would be to continue antifungal therapy, do a lumbar puncture, send it to culture and see if there is any culture positive disease, and very aggressively manage raised intracranial pressure. If the patient's sick enough to require hospitalization, then we'd recommence induction treatment for cryptococcal meningitis with whatever the local treatment regimen is. And we would keep them as an inpatient, giving that treatment, managing pressure. In people who we confirm have culture negative disease and still have problems with iris, we have used corticosteroids in that situation. It's anecdotal evidence. There's no trial evidence to suggest that that is a good thing to do, but anecdotally we've seen success in some patients. But again, we only really do that in cases where we've tried managing pressure, we've given them some antifungal therapy, and we've ensured that they're culture negative or have very low levels of culture compared to their initial culture results. In individuals who get unmasking iris, in other words, people who've never had cryptococcal disease before, who we start antiretroviral therapy on, and then they develop cryptococcal meningitis, in that cohort of patients, our standard management is just usual induction therapy for cryptococcal meningitis with whatever your local induction regime is, again with aggressive management of raised intracranial pressure. We would generally continue antiretroviral therapy in those individuals and those with paradoxical iris, unless it's an unmasking case and the person has only started ART very, very recently within the last few days.
Thanks. And I know we're at the end, but I want to give Tom Harrison a chance to answer one question that will take us into the future. That is a very controversial topic, and that is, Tom, what about just blanket prophylaxis for our patients at risk with fluconazole?
I've never been that keen on the blanket prophylaxis strategy. I mean, I guess the latest form of that was the reality trial. And I mean, for me, I think it has a place if you can't screen, if you can't screen with the CrAg test, and particularly if there's any delay to initiation of antiretroviral therapy. But hopefully those settings will become increasingly rare, where you can't screen and where there may be delays in antiretroviral therapy. But if you can screen, I think the evidence that preemptively treating those CrAg positives makes more sense. And the risk of cryptococcal disease, if CrAg negative and you start antiretroviral therapy promptly, is really very, very low. So I don't think, you're talking about treating 90-95% of people who are CrAg negative, who have an extremely low risk of disease development with a drug. I'm for selective. I have to say I'm for a selective approach based on the current evidence.
Great. On that note, I want to thank the panelists. Ray, thanks for joining. Sorry we had some technical difficulties, but it was great to hear and see your talk. Joe, Tadeo, Tom, good to see you all. And everybody, again, thanks for your comments. We will get together and figure out how to continue this format on advanced HIV disease. So For now, signing off. Have a good evening, good day. Thank you.